This is the Motherlands podcast, a space for meaningful conversations surrounding women's reproductive health. Here, we strive to shed light on the complexities and nuances, offering perspective, insight, and a profound sense of connection. We aim to empower families through practical education and promoting health and vitality. I am your host, Keely Semler. Hi there, I'm so glad to be back with you after taking a few months away from recording. That time off gave me the space to reflect on some of the dissonance I've been personally feeling, both personally and in the world around us. On a local level, the wildfires in Los Angeles that devastated two areas where I'm currently supporting clients also deeply affected me. It's been a challenging time, and I'm grateful to return to this space with you all. And there are a couple of new things I wanted to highlight before we get into the episode. One of the most significant aspects of maternity care is the ability of individuals to achieve safe, informed, and positive birth experiences, even within complex healthcare systems. Many people enter the healthcare system with unquestioning trust, unaware that financial and institutional incentives may shape the recommendations they receive from their provider. Having supported clients both within and outside a hospital setting for nearly a decade, I have observed that those who engage in proactive preparation and self-advocacy are better positioned to navigate their care effectively. Establishing open, transparent communication with healthcare providers is essential to fostering a collaborative care environment, an approach that is critical regardless of the chosen birth setting. Motherlands is an educational platform with a focus on the public health and well-being of families. This is a place to come to your own conclusions about what matters most to you and your care through pregnancy, birth, postpartum, and beyond. We have done the work to sift through the data and research to give you the most succinct information to help aid you in your decision-making. We do not peddle our own agenda or ideology, and we respect the integrity of all people to choose what feels the most empowering to their individual body. Motherlands offers a multifaceted approach to learning, providing a library of research, tools, templates, and self-guided educational videos. We also offer live group lectures and discussions so that we can grow and learn from each other's experiences. We offer two learning paths. The Wayfarer track is self-guided, where you get access to an entire library and all supporting documents, and the Pilgrimage track, which includes everything from the Wayfarer, plus access to those live group lectures and discussions. This option lets you connect with other women who are looking for support and deeper understanding as they go through their pregnancy and birth journey. If you're interested, head over to wearemotherlands.com and use the code MOTHERLANDSPOD to get 20% off your enrollment. Our guest today is Wendy Kline, who I'm thrilled to introduce. Wendy is the chair in the history of medicine at Purdue University and is internationally recognized for her work in the history of medicine, women's health, and childbirth. She's the author of 4 influential books, including Exposed, The Hidden History of the Pelvic Exam, and Coming Home, How Midwives Changed Birth. Wendy has also appeared in several notable documentaries, including Netflix Sex Explained and PBS's The Eugenics Crusade and Showtime's Pharma. I'll include in the show notes so you can connect with her and learn more about her incredible work. In this episode, we delve into extremely important topics related to power and control, the ways in which medical practices have been historically shaped by power imbalances, particularly in how women's bodies were treated as objects of medical examination rather than active participants in their own care. We also talk about gendered assumptions and patriarchy, how gendered views and patriarchal structures have historically shaped medical training, ethical considerations, and the way women's bodies are treated in healthcare. We talk about autonomy and consent, whether it can truly be obtained under conditions of power imbalance, and how autonomy has been restricted in reproductive care. Then we also cover cultural and societal influence and how the impact of cultural norms, particularly the attitudes towards modesty, shame, and the role of women in society on both medical practices and women's experiences with gynecological and reproductive health. Thank you so much for your time today. I so appreciate it.
Sure.
I thought we would start with your book on pelvic exams. I just thought we would start examining history in terms of the ethical implications of women's reproductive rights. But I'm most curious about pelvic exams have this complex and dark history, as you've written in your book, in terms of how they're used both out of necessity and in terms of power dynamics. How have cultural attitudes towards women's bodies shaped the way pelvic exams were performed historically and maybe even currently?
Yeah, I mean, I would say almost 100%, right? I mean, one of my missions as a historian of women's health and medicine is to remind, or at least kind of enlighten listeners, students, activists, that none of these things happen in a vacuum, right? They're all embedded in our culture. And it's very difficult, if not impossible, to extricate a procedure, especially one like this, right? That involves penetration from attitudes about gender and women and sexuality in any period of time. The concerns may change, which is what I found really fascinating in researching and writing this book, but there will always be something. There will always be perceptions that are embodied in that procedure and the way it's taught, and the way it's practiced, and the way it's perceived and experienced. So yeah, absolutely.
Yeah. So in your book, there's 2 chapters about 2 prominent figures, men, that sort of abuse their power in terms of performing these exams on women. Without, rereading your book, I think listeners might be interested in hearing what you wrote. So I'm just going to read a little bit.
Oh, sure.
So we're talking about Larry Nassar, who was the U.S. women's gymnastics team doctor, who I think he was recently sentenced to like 175 years in prison.
Yeah.
As well as Nikita Levy, who was a gynecologist at Johns Hopkins. And you say, of course, Nassar and Levy are not representative of the medical professionals who routinely perform pelvic exams, but their stories serve as a warning of how easy it is for pelvic violence to happen under the facade of medical treatment. These 2 men, both ironically initially adored by those they treated, got away with sex crimes precisely because of the stigma surrounding reproductive health care. What exactly do you mean by the stigma?
So what I mean is, on a very basic level, how women of any age have been conditioned to not talk about their body parts, to avoid, anything from a basic pelvic exam to oftentimes sexual trauma. And some of it comes from the ways in which the language itself has been kind of dismissed as inappropriate. Right. So I mentioned in the book in 2012, Michelle Brown, who was a state representative in Michigan, she was not allowed to use the term vagina when they were debating an abortion bill. And her response was to say the word hundreds of times on the steps of the state capitol with fellow female congresswomen by reading the vagina monologues, drawing attention to the fact that if we can't use that term because it's somehow inappropriate, how are we supposed to even have a conversation about these things? So it's anything from the language itself to feeling empowered enough to talk about experiences that happen to us. And I think that's particularly true when it's about the medical gaze, because we've been taught that authority figures and people in power kind of have a right almost to do what's medically, quote unquote, necessary. And we're not encouraged to speak up. And the Nassar story is so very powerful in telling that, because, I talk about these 2 sisters who were both abused by Nassar, and they didn't even know that the other sister had also been abused. I mean, it was that silenced as part of it. I write about a study that was conducted in 2014 in the UK about exactly this. And the study showed that young women aged 16 to 25 in general, a majority of them have trouble using the term vagina or vulva. Most of those admit avoiding going to the gynecologist for that very reason, because of the shame and stigma. So there's literally a direct link between that stigma and that lack of accessibility to basic language about your own body parts and putting off or avoiding medical treatment, right? And which could result in all kinds of health problems or even death, right? If you're avoiding seeing a gynecologist and you end up with cervical cancer. And so I think it's a very powerful way of silencing women. That was a long answer to your question. But it's really at the core, right, of why I wrote this book. You know, I mean, if you think about it, most women, well, they might talk about things like childbirth, maybe if they're in the right environment, talk about an abortion experience or a painful period, but they're not likely to talk about a visit to the gynecologist. It's just sort of accepted that you kind of bear it, you know, you just put up with it and you don't talk about it. And so I really wanted people to be aware of the importance of feeling comfortable just with basic conversations like that.
Yeah. Thank you for that. It's something I encounter a lot supporting women through birth and postpartum as a doula and an educator. And currently there is a class action lawsuit in our area. There's a provider who was known as sort of the only person willing to attempt a vaginal breech birth. So he would get a lot of business. And he was just the one guy willing to try. And so people sort of put up with his demeanor and his lack of bedside manners and also his abuse for a long time. And all of that is coming to a head. But I think just talking about the stigma around being able to even talk about it is super interesting to me, because I know this provider that this class action lawsuit is currently in process right now. And I know people that I've worked with that actually were in his care. And what's interesting is that now that it's all come out, now all these women are coming forward to talk about their experience. But it's almost like no one was willing to talk about it, or no one wanted to talk poorly about him. And I think there's something to that with women not wanting to talk poorly about a professional or about anyone, or to stir the pot or say anything bad. It is at the expense of women's bodies. So I just find that really interesting and something I come up against a lot.
Yeah, I'm so sorry to hear that. I mean, it's terrifying to think about. Every time you hear one story, you know, for everyone, there's, you know, however many others that have not yet emerged. But I think as someone who's been researching and writing about women's health for decades now, it's so clear that, you know, power includes the power of language and being able to articulate one's experience. And we have centuries of being told that we don't have the right, or sometimes in some contexts, the ability to kind of define our own experience, that needs to be done for us because we don't know any better, or it's all in our head, or, you know, so we've all, you know, in some cases, I would say, have been gaslit to think we're making it up, or it's really not that bad. Or, you know, in your case, you make a very good point. If this is the only provider, kind of balancing out needs versus accessibility versus trauma. I mean, you know, these are all decisions that people have to deal with on an individual basis. But it's really only in the last couple of decades, really since early 1970s, that we've even had this notion that women's medical experiences are valid, right? And that women are the authority over their own bodies and have the ability and should have the right to express them. But we've just been conditioned to often in these situations not believe that or struggle with that.
Yeah. Without going too much in depth about the history of pelvic exam, how did the practice of performing pelvic exams without consent or without anesthesia in the past also reflect broader societal views on women's bodies and their medical treatment?
Yeah, that's a great question. And, you know, gynecology was really born along with the development of the tool the one that we're all familiar with, the speculum. So this is the mid-19th century. there are multiple types of speculums, but in the United States, it was James Marion Sims, a Southern white slave owner, and he came up with the idea and practiced the use of the speculum on enslaved women's bodies. So right from the origins, consent was not a part of the picture by virtue of the fact that he's working on enslaved women. So they can't consent. They don't own their bodies, literally. If you think about that premise, it becomes very easy to kind of, from the 19th century forward, dismiss the idea that consent was necessary. And doctors perform certain kinds of procedures without explicit consent. I mean, that's sort of wrapped up in a lot of what happens in teaching hospitals. And I think it really was only when it was incredibly abusive and people drew attention to it that things began to change. But one thing didn't end up in the book, but I've written about elsewhere is I found a medical textbook from the late 19th century. So I think it was 1898. And this OBGYN actually was giving advice to medical students about how to perform a pelvic exam for a woman in labor. And he basically says, if she doesn't consent, proceed just as if she had given consent. Ignore her. It's for her own good type thing. And I thought about the power of that message, that it's not even kind of secretive. It's articulated in a medical textbook that's intended for medical students. And it's only when, the abuse is sustained and there's a strong cohort that speaks up, that raises awareness, that things begin to change.
Do you think that medical informed consent can ever be achieved when it comes to pelvic exams?
So there's two issues. One is how students learn how to do a pelvic exam. And that's a big controversy at the moment because over the last 20 years, it's become clear that many medical students are asked or sometimes required to practice on an unconscious anesthetized patient, and often who's in for a procedure that has nothing to do with her reproductive organs, so it could be knee surgery, right? And that has started to change. A lot of states have now done away with that or restricted the types of training that medical students can do. But the larger question is not just the training, but anybody that goes in for exam. Yeah, everybody should have the right to say no. Don't you think?
I do, but I think that it's really difficult because what I see, I'm working with a particular demographic, so pregnant women that are getting ready to meet their baby and they don't know what they're doing. It could be the first time they're pregnant, and here is someone telling them that, if you want to meet your baby, we should take a look, see what's going on down there. And they want to just do what's best for their baby, but they're not necessarily getting the full information to make an informed decision unless they have someone that's there to educate them the benefits and the risks. And someone can say, yes, I consent to a pelvic exam, but the body might be saying, whoa, this doesn't feel good. This feels off. Especially people that have been sexually assaulted.
Yeah,
so
sure.
I think it's like such a layered thing. Like consent is not just verbal. And I don't believe, you correct me if I'm wrong, I don't know how much training medical providers have in understanding, somatic awareness of the body. Like someone could be saying yes to their face, but their body is completely shut down and saying no. And instead of stopping and talking to the patient, they're just doing it and getting it over with.
Right. That's disturbing. Yes. And I am aware of that. And, cases in which patients have successfully filed suits, right, against that treatment. I guess I would say in an ideal world, that would never happen because there would be the appropriate support team, such as yourself, a doula, and the provider would be someone who was aware of the laboring person's needs, background, comfort level, and always ask consent in an ideal world. But yes, I recognize that we are far from that and that this is a real problem. It's upsetting to think that a procedure that should be a joyful one, right, and a meaningful one about bringing a life into the world has the potential to actually increase trauma rather than affirm the laboring person's perspective or experience. So yeah, I agree. It's a problem.
Right. Well, and it's also just about the bigger picture, which is the medical community has approached childbirth as this thing that needs to be cured or fixed or augmented in order for progress to occur, in order for a baby to be born. And, that kind of brings me to my next question, which is like, what ethical challenges arose in obstetrics when medical professionals began to exert more control over childbirth? Like, how did this impact women's experiences of labor and delivery?
Oh my gosh. Well, of course, I could talk for hours about that because that was really the subject of my previous book. I mean, I think there's a lot of ways to answer that question, but one of the basic ones is simply that here you have these medical men who, starting really in the late 18th century, are interested in getting involved in the childbirth process, but also wanting to differentiate themselves from what midwives do. So first, often they were called male midwives, but how they did differentiate themselves was through the use of particular tools and particular drugs. So forceps is an obvious one. And the use of and the belief in anesthetics at a time where it was really dangerous to do so, right? In order to kind of appeal to the pains, the desperate pleas for help. That gets the larger question of when we have the emergence of these medical men in their attempt to suggest they're doing something medically necessary and different from what midwives are doing, they're also attempting to prove that childbirth is a medical event, not a spiritual one, not a communal one, not a social one, right? And it's a gradual process, but by the time you get to the mid 20th century, when you start to see the majority of all births taking place in hospitals, they've kind of completely succeeded in transforming, at least in their minds, what birth is about and the meaning behind it, and that it is predominantly a medical, sometimes they would even, call it a pathological event. And they've usurped all control, not only from midwives, but also from the laboring woman who is now on his territory and feels like she doesn't have either the right or the ability to resist things that, she's not comfortable with. So it's a long history and a gradual one, but over time you can really see the extent to which it completely transformed the meaning of birth. It's something that I love teaching because I teach university age students and most of them have never heard of a midwife, or if they have, they think of it as something from the 1800s, and they don't realize that the way we in this country understand birth today is very different from just 50 years ago. And the more they learn about it, the more kind of horrified and angry they are at the lack of choices presented to them. I literally was just teaching this in my class this week, and they read Peggy Vincent's book, Baby Catcher, who did a bunch of home births in California in the 1970s, 80s, early 90s. A lot of them were like, I'd never thought about this stuff before, but it's really changed. I had some people who are pre-med who are like, this really changes the way I think about medicine and how women have been treated and what options are out there that we're just not even being taught. It's one of those nice moments where you feel like, okay, all is not lost. We can bring back some of this history, and even in West Lafayette, Indiana, and get these people to think about the implications of that history.
Are you interested in becoming a women's reproductive health advocate? I'm excited to offer mentorship to women around the world who want more guidance and support on this important journey. This 6-month mentorship gives us the chance to work one-on-one, where I'll provide personalized tools and resources to help you empower and support other women while also taking care of yourself. This work is truly needed, and I'm here to help you every step of the way. You can find more details in the show notes, and my inbox is always open to connect with like-minded women who are ready to make a difference. So that brings me to another question I have, just talking about birth. How much do you think someone's birth environment can impact the health outcomes of women and their children?
I mean, I would say 100%, right? I mean, I'm very convinced at reading all of the materials published in the 1970s when, the emergence of spiritual midwifery and books about the ways in which fear and lack of confidence and money, right, insurance, can really impact the experience of birth, which in turn can really impact the mother, the maternal infant bond, the relationship, the ability to breastfeed, et cetera, et cetera, et cetera. And then, of course, all of the potential implications of the cascade of interventions that can lead to a C-section. Obviously C-sections are often medically necessary, but once it's over 15%, as I'm sure you know, according to the World Health Organization, it's not leading to better outcomes. And so all the implications of that, and just how reading birth stories when things go right, and of course that's not always in the control of anybody, right? I mean, things just happen. But when things do go right and the laboring person is listened to and feels not necessarily in control, but like comfortable and in an environment where they feel supported, it can make all the difference in the world. As of course you would know way better than I do. I just know it from my research.
Yeah, I think when a provider, whether it's a doctor or a midwife, has a willingness to collaborate with their patient or their client and treat them like an intelligent human being that is entitled to make decisions for themselves, that requires a lot more time that they might not have as providers because they're busy, which is usually when I can step in and give them more information for them to chew on and think about so that they can make an informed choice. But yeah, going back to birth environment, I mean, I tell clients all the time, you can have a home birth like hospital birth. I've seen it. I see it all the time, but man, does it take a lot of preparation to get there and a lot of honest conversations with the doctor. And part of what I teach my clients is that you are not just a patient, you are a paying customer. And so that means you have the power to take your business somewhere else. Most of the time. I mean, when we get into the nitty gritty and we talk about vulnerable populations, they might not have a choice. And that's a real problem. And that is totally reflective in, women's reproductive health research and birth outcomes in women. People will say, oh, I like the idea of a midwife and a home birth, but, what happens if something goes wrong? And I just wonder how often women make decisions from a place of fear versus a place of empowerment. And the more information and education that is taught, the less fear there is. If our healthcare system was perfect, I would be out of a job, which would be fine. But there's a lack of education and awareness that I think is so necessary for people to make empowered decisions. So hearing you talk about your students being interested in this and learning a lot from it and starting to think about something that, might not apply to them in this given moment, but maybe down the line could, it gives me a little bit of hope.
Well, that's good. But let me jump in. When you say you'd be out of a job, I think in an ideal world, no, there'd be more of you, that it would be an acknowledged and valued part of the support team, right? I mean, I see your point, right? That
I feel lucky. I
need it.
Yeah, and I live in California, so I work with the same providers over and over again for years. I have working relationships with them. They appreciate me. I work with them. And I think that some doulas work against them. And I think that isn't necessarily productive or, help solve any problems here. I think, though, that there are only so many providers that are willing to be collaborative with a doula because they can sometimes see that we get in the way of them wanting to provide care in the way that they want to because it's, either convenient for them. And, this kind of brings up this idea of defensive medicine. Do you have any thoughts around the idea of defensive medicine or medical providers suggesting certain interventions because it's more about liability than it is about, the individual patient's medical necessity?
Right. I think that's a huge problem, right? And it comes hand in hand with medical technology a lot of times, right? Like the electric fetal monitor. If it says something's going wrong, something must be going wrong, even if there's no real evidence that that's the case. And then that's going to lead to a C-section. And again, the concern is, I mean, I won't speak for every provider, but, it appears as if the concern is more about getting sued if a C-section isn't attempted. So I think it's a huge problem. And one of the reasons why there has been in the last few decades resurgence in interest in out of hospital births for that very reason, because there's a recognition that the outcome is not always necessarily with the patient in mind, right? There are other things at stake that may or may not really be in your interest. And that's a huge problem. I know there's the study that came out in the UK in 2014, the NICE study, that basically said that,
I know which study you're referring to.
yeah, that basically said it's probably safer in the UK for healthy, non-at-risk, whatever you call that, non-risk women of a certain age to stay out of the hospital for birth for all of these reasons. And the reaction in the US was, one of horror. A report, I'm going to blank on his name, but Shaw was his last name, at Harvard OB, who basically said, the more I look at this, the more I agree. If you can stay away from a hospital or an OB in certain settings, you're going to probably be safer off, because the closer you are to the hospital, any kind of surgical unit, the more likely you are to get a C-section, right? That came out in that study. And I thought it was really fascinating that even some obstetricians are recognizing that. And then I think it's interesting how places like New York City recognized, kind of invested in doulas, because I could see, particularly among particular groups, women of color with even lower, I mean, the numbers are poor everywhere, but particularly for women of color, in terms of infant and maternal mortality, that having a doula can make a huge difference. So there is a recognized, in particular pockets and moments, that collaborative care can really make a difference, right? There's so many hurdles to it being run effectively.
Yeah, I think a lot about just this idea of risk and how different providers assess risk differently. And particularly childbirth is just an inherently risky thing. You can't eliminate any and all risk. It's just part of nature. And I think that it's been really interesting just observing how different providers, whether they're an OBGYN or a midwife, just assess risk differently. And so I always tell clients, be careful about who you entrust to give you information, because you might go to an OBGYN who says, oh, you're 35, so you're automatically high risk. Whereas if you had started out care with a midwife, she might look at you and say, you're 35, but you're healthy. Your labs are great. Everything's normal. You have no underlying health conditions. I don't see any reason why you can't have a healthy, normal, physiological vaginal delivery. So I think on that a lot. I think about how, sometimes OBGYNs sort of over-risk patients on purpose, because that's also how they're trained. They're not trained in normal, healthy, physiological birth. So how do you see the future of reproductive rights and medical ethics evolving as women's reproductive autonomy intersects with political and societal movements?
Oh boy, I wish I knew. I always joke, well, I'm a historian. I look at the past, not at the future. But obviously,
well, do you think we'll learn from the past?
I mean, yeah, exactly. We use the past to try to understand the present and to a certain extent predict the future. And, in some ways, I feel like when it becomes clear that power is being taken away, when there's a loss of power, as we are experiencing today, there's pushback. And I do think that's when groups come together. I mean, anytime abortion rights, for example, are taken away, the numbers don't go down. People find other ways. So I think it's one of those moments where I'm hopeful that there'll be a certain amount of awareness that women are entitled to safe reproductive health care, and they'll figure out a way to get that ideally. The real tragedy is about, disparities. And so it's easy for me as a white middle-class woman to make those claims. It's harder if you don't have access to healthcare or a particular community in which there are other possibilities. But in general, I think anger does a lot of good sometimes. And recognizing that this is not in anybody's best interest to basically take away fundamental rights will eventually produce some kind of positive change. What it looks like, who knows what next week is going to look like at the moment. We're in a particularly vulnerable moment, but you just have to hope that, we're not all just going to lie down and take it.
When you've been conducting research on this, what has been the most surprising for you? Anything in relation to women's reproductive health?
Well, a couple of things, but the first thing I find amazing, both for my midwifery book and the pelvic exam book, is if you go back to the 1970s and you read what women were demanding and thinking about and strategizing about, it is so frustrating because we're right back there. And the next generation kind of missed out. It's almost like in some ways they were really successful, right? Giving birth, regardless of where you do it today, is still fundamentally better than it was in the 1950s or 60s. You're not being strapped down. You're not being given scopolamine. You're not unconscious most of the time. You can sue if your doctor is fundamentally misogynistic, and we have come a long way. But I think as a result, the next generation almost took for granted that the changes and the demands that were being made were there to stay. And then people just forgot. It's almost like it got erased from the record. And so much of the material that I read, it's not all perfect. It was a different context. But I feel for those women who sacrificed so much to do what they believed in and did work so hard in the 70s, and then were right back where they started. And so it's a mixture of admiration for the kind of work they did, their resilience, and then frustration that it's sort of been lost, which is one of the reasons I write the books that I do, because I want to breathe life back into these stories. I want people to know. I want to make it accessible. I want to celebrate when celebration is necessary and valid, and want to point out when it's really not, and the fault lines and the kind of treatment that we've had as well. And to just recognize and to get people to recognize it's been a rocky journey. There has been some progress and there've been a lot of setbacks, but we need to listen to our elders. We need to listen, appreciate to what has been done in the past, and recognize what's been lost, and not just reinvent the wheel, but draw on the evidence we already have that they provided us to move forward.
Yeah, that really hits home. My mentor is 76 and she has been in this field for a very long time, and she loves to tell me about the 1970s when she was living in San Francisco and they were arresting midwives, her friends, and how her first child, who was born, I believe, 50 years ago in San Francisco, she saw the only doctor in the area that partnered with a midwife. And she said it was the most amazing collaborative care that she got. That doctor understood the importance of midwives and chose to hire and work with a midwife. And that does feel so lost. It feels like, midwives and doctors are totally pit against each other. And what if it didn't have to be that way?
Yeah. Yeah. In fact, that was another source of fascination when I was writing Coming Home, as the title, How Midwives Changed Birth. And I have a chapter on California. I wonder if I've run into anything about your mentor, but I was really struck by the extent to which there are some real heroes within the medical profession, like the doctor you're describing, who did recognize the value and who went out of their way to collaborate at a time in which that was really frowned upon. And a lot of them made sacrifices. A whole chapter on Santa Cruz and this birth center bust, and the arrest of Kate Boland that went all the way to the state Supreme Court. And the one doctor who really was kind of supportive of them and bringing them to births basically got ousted by the male medical professionals in the community. He was taking a risk because he could see the value in what they were doing. He could see the value, and he also, like many around him, was like, this is happening whether we believe it or not. So we have a choice. We can ignore it, or we can, collaborate and make it as safe and meaningful as possible. So I think that's another missed part of the story, is we tend to think of these binary terms. And in a way it makes sense, right? That there's this holistic, communal, spiritual midwifery center of care model versus this pathological medical model. And the two are totally distinct and there's no overlap. And yes, when you look at the professional organizations that represent them and the kind of conflict when they're fighting over hospital privileges or various things, yes, there is a difference. But at times that has become, through the media, through lawsuits, I think the legal system has really pushed people in corners in a way that is disappointing because it kind of forces people to take positions in a way that makes it harder to lead to any kind of collaborative care. So that was my long-winded response. But basically, I do think we've erased moments of collaborative care and replace them with this kind of oppositional stance and this conflict-ridden storyline that makes it appear as if it's fundamentally impossible to collaborate, rather than to kind of put that in a larger context in which we do see elements of it. And that was another thing that surprised me, the number of male, sometimes general practitioners, not necessarily trained obstetricians, but male doctors who were supportive of the system and really, did make a difference. And a lot of the midwives I interviewed would frequently talk about a mentor that was a doctor that made a huge difference to them. And that has gotten erased as well.
Yeah, I'm thinking of some of the most collaborative obstetricians I know are older and have seen and worked with a huge patient volume. And I'm thinking of one in particular that is incredibly world-renowned here in Southern California. And he, has known my mentor since the very beginning when she became an educator and doula. And when they first met, he said, I don't believe in home birth. It's not my thing, but if you have any clients that want to give birth in the hospital, I'll take care of them. And over time, they had the most collaborative working relationship where he saw the value of her being bedside with his patients and her client. And now he's so pro home birth that he even attends home births. So, which he would have never done as a young OBGYN. I'm curious what your thoughts are around how obstetricians are being trained now, like young obstetricians now. Do you have any thoughts on how they're trained in medical school now versus maybe in the 80s or 90s?
I don't have a medical degree. My answer is framed less by experience and more about scholarship reading. But, even in the business of being born, that great documentary, it opens with that scene of where they ask these med students and interns and residents, how many normal births have you seen? And they're like, none, right? Versus in midwifery school, where that's pretty much all they see. Right. And so they're looking at two fundamentally different types of birth, a vaginal versus a cesarean section. Right. In certain countries, including in the UK, most OB-GYNs are only dealing with that 15% who require a cesarean section, which is a very different procedure. And so my assumption is that medical training has only, kind of re-emphasize that the surgical specialty, which in some ways is good, right? You want a qualified surgeon if you need a cesarean section.
If you need to have one, they're who you want to see, right?
Yeah, but are they necessarily going to be ideal at a vaginal birth? Here's an example. It's not about birth, but I had a miscarriage when I was living in Germany years and years ago. And because we had private insurance, I was seen by the head guy who did an examination on me. And I ended up staying 3 days in the hospital because he thought he felt a cyst inside my vagina. And, brought in all these specialists came in. I had to have all of these vaginal ultrasounds and everyone's looking at it and they can't see anything wrong. But because he's like the head guy, they defer to him. And when I finally went back to my female OB-GYN later, when I got pregnant again and told her what happened, she just rolled her eyes. She's like, you have a normal cyst on this, in the wall of your vagina. It's had nothing to do with your miscarriage. He just never sees normal cases, right? Because he's so high up. And I thought, God, that's really interesting. So, a specialist isn't necessarily really trained to deal with the normal kinds of things. And for me, it resulted in a lot more trauma as a result, and expense as well. So not quite the same, but you get my point.
It's almost like the training is what silos their experience and doesn't allow them to see past how they have been trained. And I guess that's true of midwives too, because midwives only handle normal, healthy labor and birth. It's very interesting. And that's such an interesting story. And I'm sorry that happened to you. And I also know how common that is too. The conversation isn't over yet. We've still got about 15 minutes of this episode, but it's behind a paywall. If you'd like to hear the rest of it and show your support for the show, a paid subscription makes all the difference. Your support helps me cover the cost of paying my editor, providing for my family, and managing all the day-to-day expenses that make this work possible. As a paid subscriber, you'll also get access to a full extended episode plus bonus content where I share my personal reflections as a doula, midwife assistant, and a women's reproductive health educator. I talk openly about the emotional richness of this work, the art of caregiving, and share simple meditative practices to help you find calm, confidence, things I believe are valuable for all of us. Your subscription truly supports the continued growth of the podcast and the time I can dedicate to producing it. If you're unable to subscribe right now, there are still plenty of ways to support the show. You can leave a rating or review on Apple Podcasts, subscribe to our Substack, follow us on YouTube, or simply share the show with friends and family who might enjoy it. In addition to producing this podcast, I am a full-time birth doula, educator, and mentor. Your support, in whatever form it takes, helps me to continue this important work and share it with you. Thank you so much for being a part of this community, and your encouragement means the world to me. Thank you so much.